Thank you, Alberto, dear Chairman, Dr. Smith, Dick. First of all, I'm so thankful to Noor Buchholz and his kind co-chair, Dr. Al-Zaruni, for inviting me here to take part in this special event. And I congratulate them for this very successful organization of the meeting. Coming to the children, in terms of treating the stones in this special population, we have some concerns, as published in the literature, about concerning the adverse effects on the growing kidney, significant recurrence rates we have in this specific population. They have metabolic disorders more than the adults, and also we need cooperation among some different disciplines to treat these cases. However, we know that we have to combine the most effective and minimal invasive methods to accomplish a stone-free status. We should correct metabolic as well as anatomic abnormalities, and we should also have a very appropriate prophylactic regimen. How about the options to treat the stones in these cases? They are similar as the options performed in adults, as you see here. Beginning with shockwave lithotripsy, as we all know, in late 80s it has been introduced, and it has not been so far approved by FDA. However, we know after all these years, it's practical and well tolerated in these cases, relatively few complications we have, and after a single session, as you see here, the acceptable stone-free rates we see after our treatments. We have some advantages because effective disintegration and easy clearance is apparent when compared with adults in these cases. Due to this, we know that stones have a shorter duration of growth in these cases, greater stone fragility we know they have. Shock waves are damped less in small bodies of these cases, and also these cases are mobilized early and actively when compared with adults. Going through the guidelines, as you see here, it is the option of treatment in cases when the stone is less than 1 centimeter and level of evidence is 1A. However, in other stones also sizing more than 1 centimeter, it's a good option in these cases. However, when we evaluate the results with respect to the stone size published in the literature, as you see here, as the size of the stone increases, the possibility of the complications and the increase, as well as the success rates, decrease to a considerable amount. How about the age of the cases treated? As you see here, shockwave lithotripsy is also more efficient at younger ages. Published in the literature, you see here, factors, again, probably involved because of the shorter duration of stone disease, lower resistance to shock waves, and also lower absorption of the shock waves by the small body mass of the children, we may say. How about the lithotripsy type? As we see going through the literature, although the success rates obtained by the second or third generation lithotripsy are acceptable, however, in published literature says that higher efficiency and lower retreatment rates makes HM3 still as a gold treatment option in this population. That's a very nice summary of the success rates related with shockwave lithotripsy in children. As you see here, overall stone-free rates comes to 100%, and monotherapy in large stones also is highly acceptable, including also Stockholm stones and lower pole calculi in children. It is effective. Also, in one of our published study recently, we were able to show that when compare the management of lower calyceal stones in adults and in children, we have some concerns for adults, but in children, the stone-free rates are highly acceptable. Coming to complications, this is also a very nice meta-analysis and summary study published by Dr. Adesi and his co-workers, and 20 studies has been revised. Overall, 1,900 children have been treated in these studies, and as you see here, the most common cause for the high rate of complication is the stone size in this specific population. We have some safety concerns still being published in the literature related with the radiation exposure in these cases and the effect of high energy shock waves on the effect on the renal function and also renal growth. However, going through the literature, we were not able to see any significant adverse effects of binary shock waves, including very young children, as published in this nice study. So, coming to the management of ureteral stones in children, as you see here, stone-free rates are also highly acceptable when compared with adult cases. However, retreatment rates also should be always be kept in mind, and it's a little bit higher in this specific population. The other option is ureteroscopy. It has been some delay in the adoption in this specific population because indications in children for ureteral calculus are rare when compared with adults, and also even large stones will pass easily. We know it very well. However, use of large instruments in small caliber ureters and also a high stone fragment clearance after shockwave lithotripsy, additionally low incidence of stone formation in these cases, delayed the adoption of this alternative in children. Also, the physicians were reluctant due to some complications with the use of this system, concern for ureteral ischemia, and some other certain complications could occur due to the small size of the ureter in these cases. However, we know something has changed over the years. Techniques refined, equipment improved. We have some very small and fine instruments now. Durability of the equipment increased. We have now whole mimiac laser to use also in this specific population, and also the most important part is the clinical experience increased. Again, a very good overview of the published literature publications in the literature. As you see here, Dr. Smaldone and his co-workers did evaluate 460 cases in 15 studies, and as you see here, the efficacy of ureteroscopy in treating ureteral stones in children also highly acceptable when compared with adults. Also, we may have some major complications depending on the experience of the team. However, we may encounter these complications. And going through with the published guidelines, as you see here, again, treating lower ureteric stones with ureteroscopy in children is highly acceptable, and also level of evidence is 1A for this procedure, as you see here. How about use of flexible ureteroscopy in proximal ureteral stones as well as in kidney stones? Again, this is a very nice study, an overview of study. As you see here, 250 cases in 5 studies has been summarized, and as you see here, stone-free rates are highly, again, pronounced and acceptable, and when we deal with the complications, there is no significant difference when we compare with the adults. Even in very young, let's say, infants, the use of, as you see here, a publication from my country is effective in also with relatively few complications in this very young population. When we evaluate, again, the guidelines, as you see here, although flexible ureteroscopy may not be the management of choice, however, it has an impact and a place in the management of both proximal as well as stones in the kidney, as you see here. When we evaluate the stone-free rates, as you see here, in lower part of the stuff related with the stones in the lower part of the ureter, highly effective results could be obtained. Again, regarding the stones in kidney, again, as you see here, it is effective with high stone-free rates, and also, however, we should keep in mind that standing after treatment of the kidney stones is also high likely in this population. Again, this is also a very nice overview of the publications, although limited in the literature. As you see here, the success rates regarding the use of flexible ureteroscopy in kidney stones is highly acceptable in this population. Regarding the ureteral dilation, the publications did show that it does not increase the risk of stricture, and concerning the reflux after dilatation, it is unlikely to see. And as you see here, the dilatation, it differs between 1.5% to 70% in the literature, I think depending on the, again, experience of the team dealing with the children. As you see here again, sorry, the rate of standing in children after flexible ureteroscopy, and when we evaluate the causes, high-grade hydronephrosis, high stone burden, and some other problems related with the stone itself may necessitate standing after this procedure. How about the complication of ureteroscopy in children? When compared with adults, again, they are acceptable. They are not so pronounced, published in the literature. As you see here, some minor and major complications could be seen. Again, it depends on the availability of the instruments as well as the experience of the team. Regarding the use of ureteral access sheet in children, there are very limited data published in the literature, but here in this example, as you see here, intraoperative complications occur in 7 of altogether 100, let's say, children, and intraoperative complications were more common when a sheet was used. Again, that's a very nice study. It has been shown that the relative proportion of ureteroscopy increased over the years, as you see here, 24% between years 2000 and 2002, and 50% between the years 2006 and 2008. That means this modality is being increasingly performed in children. Coming to the PCNL in this specific population, following the first report by Woodside and his co-workers in 1985, also this modality had some physicians had some concerns regarding the long-term renal damage after this type of modality, smaller kidney size, relatively the use of larger instruments, radiation exposure, and also risk of some major complications did affect the use of this modality. However, the accumulated experience over the years did easily show that this modality also has a certain place in the management of stones, especially located in the lower calyceal position, as well as stone sizing having large diameter. As you see here, indications are nearly the same when compared with the adults. And when we go through the literature and evaluate the data, as you see here, the stone-free rates are really highly acceptable and then comparable with the adult cases. However, we may have some complications, either minor or major. It is also depending on the, again, experience of the team. This very nice study regarding the complications based on long-term follow-up. As you see here, no serious procedure-related complications have been observed. Also, no change in differential renal function, as well as no significant renal scar formation have been observed in children. How can we reduce the morbidity in this specific population? We may focus on ultrasound-guided puncture if we have the experience. Also, we may restrict the caliber of the instruments that we use during the procedure, and also, if possible, it has been debated in the literature, staged procedures could be taken into account. Over the years, the physicians worked on the use of small-size instruments, and mini-perk procedures came into the agenda following the publication of Jackman and his co-workers in 1998, with some proposed benefits, as you see here, and also with some technical limitations. However, we know and we use this technique in children as well as in adults now. A couple of studies did clearly show that, as you see here, it is effective, and Dr. Desai and his co-workers in 56 children did perform mini PCNL by using 14 French nephroscope, and as you see here, size of the tracts were significantly associated with postoperative hemoglobin decrease and transfusion rates. Size affects the complication rates. Again, as you see here, the authors did use 14 French mini nephroscope and 23 kidneys in 12 cases. 11 of these stones were staghorn in nature. And as you see here, the primary stone-free rate was around 84%, which has been increased around 91 after treating the residual fragments. How about the complication rates. This is a nice study summarizing the 6 different series, including around 200 children, and the size of the instruments were really effective with respect to the complications observed. And as you see here, there were no complications or transfusions in the cases where 14 French instrument has been used. Again, when we go to through the literature regarding the use of PCNL in children, as you see here, it has been used in very, let's say, young children under the 3 years of age. Again, it has been used with effective and successful data in children with anomalous kidneys. Again, bilateral performance of percutaneous approach have been published in the literature with acceptable success rates, and also in complex cases, again, this modality have been found to be successful. Tubeless PCNL have been reported in children, and as you see here, it decreased postoperative pain, it decreased the need for analgesia, hospitalization period decreased, and also treatment costs decreased in this specific population as published for adults. However, as the techniques increasing, and then it has been debated yesterday and also today, as you see here, Dr. Desai has introduced the concept of microperk, and it will be make sense in this specific population, I believe. And in his nice study, he concluded that its role in select populations, including patients with non-bulky urolithiasis, such as a lower pulse stone, the pediatric group, and patients with ectopic anomalous kidneys, will necessitate further evaluation. How about the use of laparoscopic and open surgery in these cases? Again, it is similar to adults, and it has a very, very limited role. When we go through the literature, you will find very limited data published in recent years. In developed countries, open surgery remains a treatment of choice around, as you see here, 0.3 to 5% of the children. If they have some anatomical abnormalities, then treatment of the stones as well as the management or repair of these abnormalities will be all right with the use of this either laparoscopic or open approach. However, when we evaluate the publications coming from the developing countries, as you see here, the percentage of open surgery increases due to some certain factors. To conclude, I may say that technological advances in shockwave lithotripsy, ureteroscopy, and PCNL have had a significant effect on the management of urolithiasis in children, allowing a safe and successful outcome. Minimally invasive techniques should be used to treat urinary calculi in these cases because of the greater probability of stone recurrence when compared with the adults. We know it very well. Due to the small body habitus, delicate tissues, and possible long-term complications, proper and detailed planning of the surgical procedure is of utmost importance in these cases. Despite the consensus of shockwave lithotripsy being the initial treatment, that's clear. For most stones, there are certain indications for endoscopic approach in these cases. Currently, the majority of the stones in children can be managed with endoscopic approach. Open surgery is necessary in a few and selected cases, at least in developed countries. Carefully planned and closely followed medical management alternatives will be effective in selected cases. So we should try to be as minimal as possible, depending on our experience, and be very careful not to be so invasive in these cases. Thank you very much. A scenery from Bosphorus.
Thank you very much.